I'd like to welcome you
No.
to the 18th annual Wall Street Comes to Washington conference that the Center for Studying Health System Change has run. I'd like to thank the Jane Koskinas Ted Giovannis Foundation for Health and Policy for sponsoring this conference. Through research and projects like this conference, the foundation hopes to foster discussion about cost reduction, expanding access, and improving quality. The purpose of this meeting, as it's always been, is to give the Washington, D.C. health policy community better insights into market developments that are relevant to their policymaking. So, in discussing market developments and their implications for people's health care is a core activity of HSC. I see this conference as an opportunity to tap a different source of information, equity and bond analysts on this topic. And in fact, the first time this conference was done, it was done in private, just for us to learn from. We learned so much from it, got the idea, let's do this in public, let's do this in Washington. The equity analysts advise investors about which publicly traded companies will do well, which ones will not. And bond analysts advise on the likelihood of debt repayment by various organizations, in this case, not-for-profit hospitals and other facilities that have borrowed money. As these analysts get a thorough understanding of healthcare markets and the company they follow, the better ones follow public policy very closely because it often has important implications for these companies. So today's conference is really an opportunity for these equity and bond analysts to take a break from assessing the profitability and solvency of companies and bringing their understanding of market forces to bear on key health policy questions that this audience is particularly concerned about. And we also include a Washington-based health policy analyst on the panel who helps further tie the market developments more closely to the health policy issues. The format for this meeting is a roundtable discussion. It's going to be based on a series of questions that I made up and circulated to the analysts in advance so they could think about them. And there'll be two opportunities for audience questions and answers. First, before we take a break at 10:30, and the second before we adjourn at noon. And there are question cards in your packet, and please fill them out and give them to an HSC staff member. If you want to make sure your question's answered, you can go to one of the microphones and ask your questions. Note that the analysts are not permitted by their employers to answer questions about the outlook for specific companies. And again, I want to thank the Jane Koskinas Ted Giovannis Foundation for Health and Policy for sponsoring this conference. We will be posting a conference transcript on both the HSC and the Foundation websites early next week. And you can also access a webcast of this conference from either website. Before you leave today, we'd appreciate it if you could take a moment to fill out the evaluation. It's on the blue paper in your packet, and leave it on the table outside the meeting room. These panelists don't need a lot of introduction because they're in your materials, but the panel is terrific. Most are veterans of previous Wall Street Comes to Washington conferences. Matt Borsch of Goldman Sachs, Carl McDonald to his right of Citi Investment Research, Sheryl Skolnick right next to me of CRT Capital Group, our policy expert Bob Berenson of the Urban Institute, and we're delighted to welcome a new panelist. He'll have to speak first on all the questions, Jim LeBuhn of Fitch Ratings. So let me get right into the discussion. And as I was sitting down to write the conference, I looked at last year's questions. And I wanted to begin with how different the situation is this year. Last year, the context was uncertainty about the Affordable Care Act regulations and state decisions on Medicaid expansion and insurance exchanges. Also, there was a sense that Congress and the administration might act on the federal debt, bringing federal tax increases and spending cuts into the mix. there was also a lot of enthusiasm about rolling out of Medicare provider payment reform pilots, such as accountable care organizations. Context today, not entirely different, but of course this intense focus about the uncertainty about functioning of the federal and state insurance exchanges, especially in the light of the cancellation of individual health insurance policies that do not meet the standards of the Affordable Care Act, the political reactions to the sticker shock, some of which is caused by community rating approaches used and some by the higher standards for health insurance plans, and also the degree of adverse selection by individuals buying coverage on the exchange. So let me start with a group of questions about insurance exchanges under the Affordable Care Act. And I'll begin about asking the panelists, what is your take on the ability of the federal and state exchanges to function smoothly enough for enrollment to be in the ballpark of what was projected 2 months ago? And do any of you have a prediction of the number of people enrolled to start coverage on January 1st or by the end of the enrollment period on March 31st? Look right first to the managed care analysts, see if they'd like to start.
Sure. Yeah, so I guess I would say no to the first part of the question. Enrollment projections aren't going to get to where we thought a couple of months ago. My specific projection, I mean, I'm in print saying that there was going to be more than 7 million people enrolled in exchanges by the end of March 31st. Different composition, though, than I think what CBO was looking for. So CBO had talked about 7 million exchange enrollees next year. The breakdown there, 4 million previously uninsured, 2 million people who have individual insurance today switching over, and then 1 million people getting dropped by employers going to the exchange. I thought the previously uninsured number, the 4 million, was too high, but I thought that individual switching over to private exchanges was much too low. There's 10 million people in the individual exchange market today. Half of them are eligible for subsidies. So I thought you potentially could get 4 to 5 million people that have individual insurance that switch over, and that would push the overall number above 7 million. But where things stand today, with the issues that that we've had, I think it is going to be a challenge to get anywhere near that number.
And if I could just add to that, we have a forecast, and it was also like the one Carl was using, 7 million, because that pivots with where the CBO projection still is, because I don't think they've put out a revised projection. Having said that, 4 weeks ago, we revised our projection for exchange enrollment down to 5 million. Now, honestly, there's no science here. It's really, you're just making a guess. But at the same time, it seemed that we really needed to factor something into our forecast for all of the problems that the exchanges encountered, and the fact that even if those issues are resolved quickly, that you're still probably not going to get as much enrollment as we would have expected. So we're down to 5 million, and that's 2 million from the uninsured and 3 million switching from existing plans.
What are the indications about the mix of younger and healthier people enrolling before the end of the open enrollment? I noticed the Wall Street Journal article says November 5th. I guess that's where I did my first draft of the questions, indicating that early enrollment was mostly older people. Anyone have indications of, in a sense, how bad the adverse selection might be?
Yeah, I mean, it's going to be bad, but I don't think that should really surprise anybody, at least at this point. So, you see the statistics. The one everyone's talking about is Connecticut. I think the number there was 40% of the people are above the age of 55 in terms of those that have enrolled on exchanges so far. But I don't think that should really be surprising, particularly given the website issues. If you're sick, you are willing to sit there every day, all day, and wait and wait and wait to try to get through that. Whereas if you're healthy, you're just not going to. So, I think that's, like I said, that's not surprising. What was interesting to me, though, is the number of people that got exchange coverage that weren't subsidy eligible. So from the national statistics, 30% of the people that have signed up got no subsidies. California exchange, it was, I think it was only 16% or so of the people that were subsidy eligible. So very, very low numbers. That part was actually somewhat surprising to me. So again, gives you an indication that people that are signing up, most likely probably not great health status.
And actually, Bob, what are the scenarios that you can envision? Let's say adverse selection turns out to be pretty intense, of how government would handle this.
Well, I guess the one tool that's been talked about is the risk corridors. Whoops. I don't have my phone on. Are the risk corridors, which basically would protect plans who have adverse selection, the amount of risk that they have. So I think that's already been talked about, is sort of providing more protection there, and already that's become a political issue. I believe that Senator Rubio has sort of come out and opposed the notion of what he called bailing out insurance companies. So that is a tool. I suppose you could do some tweaking of the risk adjuster also, but I don't think that's ready for prime time.
Thanks. If the individual mandate were delayed, say by a year, would that have a significant impact in the degree of selection?
Paul, let me just say on that question also, just with reference to the last one as well, that I don't know that the individual mandate would have that much impact on enrollment at this point, just based on everything that I've read. The point just I wanted to address on the prior issue is what is going to be the real, or could be the real dilemma as we get into next year, is if we have a very skewed insurance risk pool, the actuarial tendency then at the carriers will be to price higher for that risk. Let's say for sake of example, 20, 30% rate increases, which somehow that has to be avoided, because that will only make the problem, as most of you in this room probably know, the way insurance risk pools, that could only make the problem worse. And so there probably will have to be some measures taken if the skew is that strong to prevent that from occurring, new money to subsidize the pool or something like that.
Yes, and I think there's even a possibility that even if the government puts in new money, probably its spending would still be lower than projected because of the lower enrollment of healthier people who won't have to be subsidized.
That's a good point.
Sure. Given the political climate, are you expecting any near-term legislation or regulatory decisions in response to these developments?
Yeah, I would say that it all comes down to November 30th. If the website is not functioning on November 30th, then I think you see a stampede of Democratic legislators in risky elections this year, find legislation as fast as they can to delay the individual mandate, extend the open enrollment period, all of those things. I mean, I think the scenario that everybody's worried about is somebody whose insurance has been canceled, who can't get coverage because the exchange isn't working, so they go uninsured on January 1st. Something bad happens to them on January 2nd. They end up in the hospital with a $50,000 bill. If that happens in your district, game over. At least that's, I think, the feeling that a lot of people have right now. Now, obviously, there's a long time between now and the election, so various things are going to happen. But I think that's going to be the fear that the Democratic legislators have if this website isn't working by November 30th.
So can I make a couple of observations? Because I cover both the hospitals and one managed care company, who happens to be United Health Group, who happens, as some of you may know, to be the owner of Optum Insight, which is the owner in turn of QSSI, which has the dubious honor. This is how corporate structure works. Which has a dubious honor of being the general contractor assigned, tasked with finding out what's wrong with the exchange and managing the process of getting it fixed. Notice I said managing the process of getting it fixed. Different than getting it fixed. So I find it very interesting that this all comes down to the capability of a general contractor owned by a managed care company that is elected to participate in only 4 individual exchanges and 12 in total. They know something about their risk pool. They know something about their benefits business, but they went out and bought the company that had the contract for the data hub and one other piece, the front-end enrollment piece. So the observation that I want to make is that, from a technology perspective, we are very much reliant on the ability of United to get this done. And they may well be the only entity that understands enough of what's going on to be able to get it done in order to know whether or not we're going to have a turnover in the Democratic Party. I mean, their role is absolutely crucial in this. They're going to determine what happens in elections. They get it done, and maybe the Democrats don't stampede towards the exit on the ACA, and people actually get insured. They don't get it done. I don't want to know what's going to happen to their Medicare Advantage reimbursement next year. They'll probably get dinged even more. But something's going to happen here, and it's going to be very dramatic. From a hospital perspective, I have to tell you, we analysts following the hospitals have all assumed that this was going to go fairly smoothly, not perfectly smoothly, but fairly smoothly. And we've put some pretty rich numbers into our estimates for next year as, relying on, we do our own projections for exchange-based coverage, for Medicaid expansion coverage, and for the Arkansas solution, which is sort of neither. And we come up with some numbers that look pretty robust if you actually got to anything close to the CBO numbers. $1 billion in incremental profit for HCA alone if you get to the CBO numbers. So you don't put quite that much in, but we're at a very tender point right now, both for the managed care companies and for the hospital stocks, with this massive uncertainty and this reliance on November 30th, which happens to be the Saturday after Thanksgiving. Okay, so it also falls on a weekend. So, this is setting up to be quite an eventful holiday. And I will be cooking despite that. But then after that, we're all going to be, waiting and watching and wondering what's going to happen on Monday. Because I don't think any of this is going to wait until January. I think the reactions are going to be very swift and very acute, especially on Wall Street.
Now, speaking of November 30th, this isn't like seeing where the Standard & Poor's average is on November 30th. In a sense, making an assessment of how well is this exchange working? Not a simple thing. I'm wondering if there'd be any good information at that point or a week later to actually make judgments of, is it doing its job?
There better be. There has to be. They've created the expectation that on November 30th we'll know and we'll get a report. And, I think it's fair to say that, as Carl suggested, it all comes down to what happens November 30th. We better find out something.
And one thing I think at least people should be thinking about is just the number of people that will be visiting the website. Let's say we get the all clear sign, it works on November 30th. Yeah, they said healthcare.gov was originally scaled for, 50,000 simultaneous users. The first couple days after October 1st, it was 250,000. That created some problems. You're now basically taking a month and a half worth of open enrollment and trying to cram it into the first 2 weeks of December. So is it conceivable that you could have 1 million, 2 million simultaneous users on the website at the same time? I have no idea, but I think from a scaling perspective, when you give that all clear signal, you have to make sure that you can handle very, very significant volume because you can't have a situation where you say it's fine, everybody goes on and it crashes again. Because again, then you will see the legislative response.
Good. Let me turn to employers. People always speculated about, what are small employers going to do? Are they going to stop offering coverage right now, in a year from now? And let's forget about 2014, because I don't think any employer that cares about having their employees continue to be insured would drop out at this point. But let's say for next year. Do you expect some major changes in behavior of small employers?
If I could just offer, probably if the exchanges are functioning over time, we will see some migration. It's going to depend, if you think about it on two dimensions, if you will. One question being the tax preference, which goes to those who purchase coverage through the employer, and that's the advantage to keeping coverage at the employer level, or at least one of the big advantages. The other side being the subsidies that are available on the exchanges and only on the exchanges. So just to state the trade-off that many of you are already familiar with is you move down the wage scale, the value of the tax preference decreases, and obviously the subsidies come more and more into play. And so I think wage mix as well as profitability is certainly going to be a factor in determining which employers take up, push their employees into the exchanges as an alternative. And it can be a win-win the way that it's structured today if it stays that way.
And I think you will see some employers drop coverage even this year. So if you think about the 20 million people in small group coverage today, CBO is projecting 1 million of those would move into the exchange. If you're a micro group, so you have 2 employees or 8 employees, you really can make that decision December 26th or December 28th. You don't need necessarily a lot of lead time. So if the website is working by then, or you happen to be a small group in California or a state where the website is actually working, dropping coverage, I think does become a more viable option. And I think to Matt's point, my view is if you're a small employer and your average wage is $25,000 or $30,000, it's really hard to see why you would continue to offer coverage relative to all the free money that the government's going to give you. I think that'll take a couple of years to happen, but I do think the lower wage small group employees will ultimately find themselves in an exchange.
Well, and I kind of think as well as larger employers, as you get some of the Home Depots of the world that do it, it becomes more acceptable as a benefit program to push people into the exchanges.
That's right. What about small or medium employers converting to self-insurance in order to avoid the community rating and taxes like the health insurance tax? And do you expect states to be actively engaged in blocking this?
If I could just offer one point is just as background, it's only, correct me if I'm wrong here, but I believe it's only the truly small group employers who are now nationally subject to community rating, and that only has impact in states where they weren't already subject to community rating. The medium-sized employers are not actually subject to community rating. Having said that, clearly there's been a shift towards self-insuring in what we call the middle market. Say employers with 50 to 1,000 employees. Above that level, it's traditionally been predominantly self-insured. So there's been a conversion into self-insurance. I don't know what the exact proportions are. I think still more lives in the fully insured status. Will that continue? What we've been hearing from some of the companies that have the closest view of that is that the shift has been continuing at about the same pace. So we have not actually seen an acceleration. It surprised me a bit. We have not actually seen an acceleration ahead of the implementation of January 1 and, of course, the imposition of surcharges for, well, notably the surcharge for the insurance tax, because the other surcharge being the reinsurance applies to all employers, self-insured or fully insured. And as far as states enacting more statutes like California has to bar the small, maybe at the truly small end from self-insuring or making it effectively difficult, some will, no doubt. I don't have specific predictions there.
And I mean, my perspective, it's a factor, it's not a decider for a medium-sized employer to go to self-funding. So if you were already thinking about doing it, maybe this is what pushes you over the edge. If you weren't thinking about it at all, then this tax alone isn't going to cause you to switch to self-funding. One other point to think about is we've seen a lot of news about private exchanges. The Aon exchange in particular is self-funded employers moving over to risk status. So that would be sort of a counter example to that.
Yeah, that's actually something I'd like to get into later in the session. Let me talk about Medicaid expansions. And of course, many states have not expanded Medicaid, although we recently saw Michigan and Ohio join as a result of strong pushes from their Republican governors. What are you expecting over the next 2 to 3 years as far as additional states joining?
Yeah, I mean, my perspective is that it will happen. I think a lot of the opposition that you saw to Medicaid expansion, at least initially, was a lot more politically driven than it was financially driven. And so I think as those issues start to come up. So hospitals that are still covering uninsured people are not getting paid what they could be getting paid. Employers that would have had employees that would be Medicaid eligible, that the employers are still having to pay coverage for that. I think over time you're going to see more, and that's sort of consistent with what you saw Medicaid initially. Initially when Medicaid were rolled out, some states did it, a lot of them didn't, and over time, ultimately, all of them ended up with a Medicaid program.
So if I can just make an observation from a for-profit publicly traded hospital perspective, there's really only a handful of states that matter, Texas and Florida being the two biggest that matter. I think the political climate in Texas has to change a lot for us to see Medicaid expanded there. They seem to be very well satisfied to have the poorest of the poor remain uninsured, which seems to me to be an odd policy outcome for people who get reelected, but that's just me. On the other hand, Florida, I think, could prove to be more interesting. That's a place where you had the governor adamantly opposed and then reverse himself, and a staunch opposition from the Republican House prevented the expansion from happening in the first go-round. We're getting some sense that it may not be completely dead, just mostly dead. And it probably will, come back, but I do have to wonder whether a failure of the exchange would make the question somewhat moot.
I tend to think that you are going to see, I agree, I think you're going to see an expansion. I think the dollars that are available are just too great to pass up, and I think in terms of those states that choose to expand versus those that don't, I think the political pressure is going to get increased as you hear some of the stories about the populations in Georgia, Florida, Texas, and the impact of not expanding, what that means to the uninsured and the poor.
Now, for those states that are expanding Medicaid, have there been important shifts towards managed care or changes in the approaches to managed care?
If I could just offer, I think in general, the push and then enactment of health reform in its form of essentially embracing managed care plans in its structure for insurance coverage expansion has, I think, provided a push at the state level towards managed care for the Medicaid and dual eligible population, as has much of the dialogue around long-term entitlement control plans and trade-offs. I think that's fed into it. And so you are definitely seeing, you have seen, and I think it will continue, aggressive activity by states to push, if they're not predominantly in managed care, to push there, or more, what's more relevant is taking the high-spending, more vulnerable cohorts of the Medicaid population that haven't been in managed care and converting them into managed care plans.
Yeah, if I could jump in on this one, I think the Duels Demo that has been started at the Innovation Center, which, as I understand it now, 5 pretty large states are using a Medicaid managed care strategy for duals. California, Massachusetts, Michigan are significant, and it's called a demo, but when you're moving a couple 100,000 people in LA County into Medicaid managed care, it seems to me a little more than a demo. It's sort of reflects like a waiver. I don't know how you undo it if in 3 years you decide it hasn't worked out. So that's a major impetus, at least in those states. And another factor that's going on are the move in, at least in a few states, towards ACO analogs, including Medicaid as, in some cases, as sort of the catalyst. So Oregon, Colorado, Minnesota, and our 3 states. The SIM grants, the State Innovation Model grants that the Innovation Center has awarded to a number of states, either for feasibility planning or implementation. A lot of those proposals had to do with delivery system reform with Medicaid playing a central role. So I do think there's a lot of activity in this area.
Just one quick thing. One of the things we were hearing early on as the states were kind of trying to figure out how to approach this once they decided to opt in was that they realized that the federal monies coming in for the expanded lives might actually provide them with the ability to segregate the newly covered lives from the existing lives through different managed care plans, and actually pay the plans a little bit more, because there was a fundamental problem of what does this population look like? How acutely ill are they? What are their utilization trends going to look like? And the way they thought about doing this was actually pay the plans more to pay the providers more, not per unit, but because there's going to be more units of care delivered. And I thought that that was kind of an interesting move. I heard about it for about 2 weeks, and then it vanished. So there may still be new payment models out there for segregating, as you said, segregating the population. But it may be segregated not by ill, not ill, but by new versus old.
That's a good point. Now, what Oregon's doing with its coordinated care organization, are other states likely to follow that?
Yeah, I think it's probably still a few years off before you see that. So I think the other states, I think, would want to see some definitive evidence that what Oregon's doing is actually having a meaningful effect before they would go there. And I think it's a little bit difficult to go from a state with a Medicaid managed care focus model to what Oregon is doing. So you'd have a pretty big shift there. So I doubt you'd see a lot of states ultimately go through with it. I think before any of them did, I think they'd want to see some real evidence.
Now, HSC did a study of the Portland, Oregon insurance market, and heard a lot about the coordinated care organizations. And what strikes me is that the delivery system in Oregon, or in the major cities in Oregon, is really quite different than in most other areas. It's very integrated. Almost everything is in large organizations. Physicians are already integrated with the hospitals. So in a sense, this idea about coordinated care organization probably would not fit very well in a more typical delivery system.
Yeah, that's why one of the other states that is doing this is Minnesota, which also has that kind of organized medical group delivery system.
Sure. How is the uncertainty about expansion affecting Medicaid managed care plans, and how much interest do the for-profit Medicaid-only plans have in getting into the commercial market by the exchanges?
Well, I think that remains to be seen is the answer. What we've seen from Medicaid plans, both for-profit and not-for-profit, is them in many cases putting offerings on the exchanges that seem initially designed towards the very low income part of the commercial population that may cycle back and forth between Medicaid and commercial, and it makes sense for them to have the plan offerings there so that they can stay with that same health plan as they move back and forth between the thresholds. Now, what will be interesting to see is in many cases these plans are the cheapest ones available, not in every case, but in many cases they are the cheapest or at the lower end of the costs on the exchanges, and there's nothing to prevent moderate or higher income individuals from choosing those plan options. The trade-off is typically much more restricted networks of providers that have historically been more oriented towards a low-income and Medicaid serving population. And so, whether that would work for a higher income segment of the population will determine if you'll see, I think, an expansion of the plans into the commercial arena more broadly.
Yeah, that's a good point. So in a sense, the initial entry into the exchange commercial market is really to continue to meet the needs of the population they're familiar with. And that's probably a lot easier for them to do than to go up market, since everything has been designed with limited networks to keep costs really low. Unless middle market people are so desperate to save money as well that they are willing to put up with the restrictions of those plans.
Right, and that's not really tested.
That's right.
One thing that I've noticed going through the exchange buying process in a number of federal, well, I haven't actually got through the federal exchange, but on some of the state exchanges, is that it is almost impossible to figure out who's in and out of network. So if you're a consumer and you're buying on the exchange, all you see is the Molina plan, might be $50 or $100 cheaper than anything else out there, and you pick it. And it might not be till after the fact that you find out that the only providers you can see are the inner city, and you don't necessarily want to drive there. So that'll be an interesting dynamic to see how that plays out. I think another interesting dynamic from a Medicaid perspective is how do you deal with out-of-network spend? So if you're Aetna and you have a limited network, at least you have commercial contracts with everybody, and as a worst case scenario, you have a PPO arrangement with the provider. So you have some type of contracting arrangement that you can point to if somebody goes out of network on an exchange product. If you're a Medicaid company, you don't necessarily have that. So there'll be some interesting dynamics to see how that plays out. When you do have some of these Medicaid exchange plan or enrollees, end up out of network and end up with some giant bills.
How do provider payment reform models such as medical homes, bundled payments, ACOs fit with Medicaid managed care? In a sense, is it something where the state program is saying, we're gonna do this, and each of the plans has to play their parts, or does it actually come more from the plans?
Yeah, I mean, to date, other than some of the states that Bob mentioned, where it is more top down, it has very much been left to the plans to do. But it's a lot harder at the Medicaid level to get into a lot of those arrangements. So think about an ACO. You walk into a hospital or a doctor, and they say, okay, our baseline is we lose 40% on these Medicaid members. So you want us to enter into an ACO where now we're going to take risk, and best case, we're still going to lose money? There's not a lot of receptivity to that. So I think it's a little bit harder, given the payment levels in Medicaid, to make some of these different provider reimbursement methodologies work.
And I have to say, from the hospital perspective, they are, a lot of these risk-oriented or innovative or more coordinated programs are still, just to be kind, they're still very much on the drawing board ideas. I mean, there are clear examples of collaborative models and risk-bearing models, clinic models that are successful. But by and large, it's not happening on Main Street. And the reason it's not happening on Main Street is that hospitals have learned to take a very cautious approach to bearing risk. And so there are certain risk-bearing arrangements that they're engaging in. There are some ACOs out there. But most of the hospitals are still taking very much of a, we're interested in taking risk if it's the right arrangement. And that's almost always on a commercial or maybe a Medicare Advantage, but almost always on a commercial contract with a particularly innovative employer and a particularly robust clinical and financial information system at the hospital in an integrated way with their downstream providers.
Sheryl, I wonder if the typical hospital that might be interested would be one that's already doing a lot of this with commercial payers, with Medicare ACOs, and says, well, if I'm changing the way I deliver care, I want to get as many of my contracts aligned with this as possible.
It is more likely to see that. I mean, where we are seeing it are where the physicians in the hospitals are already integrated. They're already functioning as a clinic or as a system, sort of replicating Kaiser without being Kaiser, so vertically integrated as well as horizontally integrated. And I can think of a couple of systems in Florida and a few others around that are very well positioned to do that. And it does make a lot more sense. It's a lot more efficient if you can treat your patients all in the same way, so that you don't have to direct your clinicians, be very risk averse with this one and go for it with that one. It's really hard to direct that kind of decision making at the bedside.
Yeah, I was going to say, I think perhaps and I don't know how you feel, Sheryl, on the not-for-profit side, they've been maybe a bit further ahead. They've been willing
much more willing.
Exactly. And I think, but I agree with you. They're kind of dipping their toe in the water to kind of get a sense, to develop that skill set. But as you know, they've been straddling this fee for service versus trying to adjust and move the organization towards fee for value or payment for value. I think the medical homes are a very interesting area that there's a lot of focus. It makes a lot of sense. I think the ACOs and the bundled payments, again, the ACOs kind of, I think the feeling in terms of the not-for-profits that the ACOs, because you can't attribute those patients to your organization, they can kind of move in and move out, has really been sort of a letdown. And I think organizations put a lot of time and effort into it, and they didn't see a lot of value out of it. And there were just some concerns about the way the whole program was set up in order to get the benefit of changing that population health. But I think the medical homes are an area of big interest for organizations moving forward.
What about primary care supply? We have in some states very large expansions of Medicaid, and how are the plans coping with the prospect of having a lot more people, having a stagnant managed primary care supply, and how do you think this will fall out?
It's, I mean, I think it's going to be a challenge. To your point, the pool of physicians isn't changing, the population is. I think plans look at the experience in Massachusetts, where you look at how much emergency room utilization increased in the year after health reform was implemented in Massachusetts. Some of that was consumers not necessarily understanding they now had a primary care physician. So some of it was behavior changes, but in many cases it also was access issues, particularly in some of the more urban areas.
I think it's interesting. I think primary care, we're kind of back to the 90s where everybody's sort of scrambling for primary care. You've seen some of the big insurers out in California looking to lock up that primary care as the gatekeepers. I think going forward there's some policy issues and perhaps the AMA in terms of what physicians actually have to do. Right now it's so physician-centric, and I think going forward there's got to be a way that you can leverage primary care physicians, their time, whether that's through allowing nurses to do more of the routine care for people that come in, or using telemedicine. I think Kaiser's done a great job in terms of using technology to be in touch with patients, but not have those patients come into the office. You can answer routine questions that normally people would come in. So I think there's technology issues, and I think there's also policy issues that can be used to leverage the use of primary care physicians.
Yeah, it's one of the sort of underlying theories of the medical home would move. I mean, I guess the phrase everybody uses is that they have lots of different health professionals practicing to the top of their license, with the implication that the physicians don't have to see every patient all the time. The early results are mixed in terms of the success of the medical home, although, sort of anecdotally, the practices who were the early adopters sort of like it. It's not clear what the impact is going to be. And for the most part, I think it's true to say that insurers are still in the demonstration phase and not sort of throwing big money into the medical home or primary care pot. I think Anthem has gone a little further, but not in a huge way. So I think it's still in a trial phase.
So there has been sort of a series of arms races within the foreign not-for-profit hospital sector to acquire certain types of assets or build certain types of buildings or start certain kinds of programs. And the latest one is kind of a back to the future scenario of buying physician practices. And a couple of the times we've done this, it's been let's buy specialist practices. Now it's really focused on primary care. And one of the companies that was leading that charge was actually Vanguard Health Systems, which is now part of Tenet Healthcare. And they have, especially in their San Antonio market, really focused on acquiring those practices that are primary care because they understood pretty early on that primary care was going to be the key to all of these innovative arrangements, as well as the key to being able to have better negotiating leverage with the managed care plans. So it was interesting that it occurred in Texas. It didn't occur at Detroit Medical Center, where they had the Pioneer ACO, which I'm not sure worked so well, by the way. But it did occur in Texas.
I've actually seen in some of the site visit work we've done in California, a real interesting dynamic in the primary care market where, a lot of the care for the low-income people has moved into community health centers and rural health clinics and all organizations capable of paying them more than, say an independent practice can earn seeing low-income patients. And I think, as Sheryl mentioned, I think it will happen in hospitals too, of hospitals recruiting primary care physicians, paying them more because they know how important they are to the delivery models they'd like to pursue. And I guess it'll be a while before we know who gets left out with no chair as all this dynamics works through. Let me change the topic to the outlook for spending trends. And we talked about it last year. And since then, low spending trends have continued, maybe even gotten even lower. And maybe the major event of the year is all the attention it's gotten from researchers like, I remember in this venue, very interesting Altarum conference that a number of people here, including me, went to a few months ago about this. And so let me just open the question to the panelists again about what do they see as the key factors behind the last few years of relatively low spending trends?
Paul, if I could just take a stab at addressing that one. I think most people look at it will ultimately say multiple factors are at play here. One of the struggles is to identify how much of the slowdown relates to the broad economic environment, both the Great Recession itself and then the slow recovery and lagging employment picture. One thing we and I think the answer is a great deal of it, but not all of it. As we've looked back over multiple decades and building on some of the work that that the Milliman actuaries did back in the 90s, we've looked at the relationship between economic cycles and health spending trend, where you have this, of course, is a generalization, but there is, you see this pattern occur in the 80s and the 90s, to a lesser degree in the last decade, where health spending trend slows, really starting at the end of a recession, and that slowing or period of depressed health spending growth continues for several years. Maybe 4 or 5 years before then you start to see a pickup. We saw that following the '82 recession, with the pickup coming in the late '80s. We saw that certainly after the early '90s economic slowdown, with the pickup coming there in the late '90s. And again, I think it's still there to a lesser degree in the last decade. And the driver there each time is partly long lags of employer responses to the economic pressures, and health spending trend being one of them, and changes to benefit plans, whether it's shifting into managed care or an accelerated push to higher cost sharing with consumers sensitive to that in a tough economic environment. Those things then have a multi-year impact on health spending trend.
Yes. So, Matt, you're thinking that that's still the core reason that we're seeing. And at what point, of course, we don't know what the economy will do after today, but given the economic performance so far, what's baked into the future at this point?
Well, I will. The interesting thing is we built a multiple regression model. Again, this is originally work that the Milliman actuaries had pioneered back in the 90s, but we took it forward to the present. And this was actually almost 2 years ago we introduced this model, and what it predicted was continued sluggish spending in 12, and then actually a dip in 2013, and then a pickup in 2014. Now, this is a model. It's not looking at current predictors, really. It's looking at the lag between this recession and how that relates to the pattern that we've seen in prior economic cycles. It was interesting, and frankly, I didn't really embrace it, but it was interesting that the model pointed to further slowing in 2013, which arguably is what we've seen. Now the question is, will we see some pickup in 2014, irrespective of health reform implementation? You know, the pattern suggests we will. What may significantly dampen it is the model doesn't really take into account that this has been a much slower and less strong recovery than the prior ones that we look at.
So can I ask a question? Are you looking at spending from the perspective of demand, or are you looking at it from the perspective of price and price controls and reimbursement policy? Because it's somewhat of a self-fulfilling prophecy. If you live in an environment, as I used the phrase last year, of starvation in the land of plenty, lots of old and sick people and no money to pay for them, and you also have budget crises, it shouldn't be a big surprise that the cuts that you put in place to pay for reform and everything else have an impact on the level of spending. Because, you know, everyone's pulling in their horns. The other thing we're seeing from the hospital's perspective is that the managed care plans are increasingly managing care. And they are affecting and influencing consumers' decisions, patients' decisions, and directing patients to not only a narrowed network, but within that network of site of care. So it's not even just a site of care, inpatient versus outpatient, but which outpatient provider. So the level of sophistication in directing where care takes place, and therefore presumably not just the price per unit, but the cost of the episode, is getting pretty intense right now. And the hospitals certainly are feeling it on the issues of observation stays versus short stay admissions, and we're clearly seeing a conversion of inpatient to outpatient. Technology does play a role in this, but not always to lower price, just to change site of care. But the hospitals in response are having to, they're having empty beds. And so they're having to cope with the fact that their high fixed cost environment has to have some revenue from someplace, and they're shifting also into the outpatient world. So they're becoming more accepting of the shift in the management of care. So I would say, in addition to everything that Matt said, which I agree with wholeheartedly, I'd actually argue in the absence of reform, next year is not going to be a rebound. Just from the perspective of what's happening, I don't see any real change in underlying fundamental demand. We all wonder where the elective patient went, and we all wonder where the hips are. Okay, I mean, we're getting older. Where are all the hips, and where are all the needs? And we're seeing a little bit of that, but we're not seeing nearly as much as we should given the demographics. So I think there's an awful lot going on at the intersection of managed care and the practice and site of care, in addition to the fact that you're just squeezing down price.
Sheryl, along those lines, I'm curious, anecdotally, I think in the not-for-profit space, what we've heard is I think there's been a large impact or a large effect from high deductible plans. I think consumerism is really impacting the use of care.
When you're self-insured, it matters.
When you're paying the first $5,000, I think those elective surgeries, I can wait. And I think, so that's one thing. I think also hospitals have taken upon themselves. There are penalties now for readmissions. I think, you've seen better clinical care. And so some of those readmissions that you were getting paid for by Medicare, you're not getting paid for now. And I think in the not-for-profit and for-profit space, the improvement in clinical quality has had some effect of it. And then lastly, particularly in the not-for-profit space, when you look at spending, supply costs have been a huge area where they've been looking to come together. I mean, the not-for-profit space, for lack of a better term, it's sort of been taken advantage of by suppliers because of the fragmentation in the market. And I think with some of the consolidation in the industry, as well as movement and banding together on group purchasing organizations, they've really been able to squeeze down prices that suppliers have been charging them. So I think those supply costs reverberate through the system.
They've been pretty diligent about that, but of course with hospitals being price takers in almost all of their business lines, the only one that really matters where they have some negotiating leverage is if they have market share in managed care and they go up against their companies. And there, I think we're seeing a little bit of a slowing. The range is still the same. It's still like 5 to 7. But we're not seeing a 5 to 7% rate increase every year, but we're not seeing that range changed much, which tells me it's moved from the top to the bottom, maybe. And if you really want to crack the code, I think what you'll see is the 5 to 7 doesn't need to be there because you don't need to cost shift quite as much. And then we'll see another step down in the level spending.
And let me just make just a couple of points. One is that this flattening of use of services, not only presumably from high deductible plans, managed care, but it's also happening in traditional Medicare, which doesn't have high deductible and doesn't have utilization management, although there might be some spillover from what's going on in managed care, but it's flat there as well and has been flat for about 4 years. So something I don't think we fully know the answer as to why use is down. Second, I was interested in your comment about 5 to 7%. You're saying that hospitals are getting 5 to 7%?
Some are.
Some
Certainly
are.
the publicly traded companies will tell you that they're still kind of in their historic range of price increases.
Because I've been reading the Alterum sort of monthly reports on pricing, and from about the summer of 2012 through today, prices that hospitals are getting seem to be 1 to 2%. In fact, for the first quarter ever, in years, utilization increase outpaced price increase. Now, I want to make one caveat on that. I was talking to an insurance executive just the other day who said, the prices are down, but the incentive payments were given to hospitals is what's making up for that.
You're going to look at what kind of a rate's that, and I was going to say it's also in the terms and it's also in the quality, and more of the contracts are shifting over to pay for performance. So there are some quality bonuses in there as well.
But it's not being
and
captured
also
in the
remember,
price.
when you average all of this in, you're also averaging in the hospital with the largest networks and the #1 market share in most of their markets, namely HCA, which tends to raise the average.
Okay. But in any case, in terms of just understanding what's going on here, we have to see if some of the payments are not being captured in price. And the third point I would make, and it's timely because the Council of Economic Advisors just released a report yesterday sort of congratulating the Affordable Care Act on restraining healthcare spending. And I think it's a little too soon to say that ACOs have made the difference, which was in there. I think it's more straightforward than that, and it's partly based on work that MedPAC has been doing and Chapin White of the Center has been publishing in recent years, is that when Medicare cuts its prices, which it absolutely did in the Affordable Care Act, hospitals reduce their scale of operations, and they don't cost shift onto private payers. They cut back. So when Medicare cuts prices, that has a restraining impact, and then the hospitals are in a position where, if you go all around the country, hundreds of people are being laid off at every healthcare system, who in many cases are, I think, in pretty good shape, and yet they're feeling pressure to scale back. And I think it may be more directly, it's a traditional impact of what Medicare does rather than new innovative payment models.
Robert, if I could just offer one other to that, which is that all makes sense. I just want to comment that as we look back in patterns in the past, the correlations aren't as strong, but we have seen slowing in traditional Medicare utilization correlate with economic cycles as well, which might seem somewhat counterintuitive, but interestingly, there's actually some academic research that there's even some of that correlation seen in single payer systems where you wouldn't expect to see any. And so just to point to that as a factor in the mix.
That's right, and that could well be the case.
Just one more thing I just want to throw in. Just within the employer market, cost trends aren't really decelerating anymore. 2013 was really a flattening in the cost trend. So you're still seeing it in healthcare spending broadly because hospitals and doctors and Medicare, Medicaid never get a rate increase. But within the commercial group population, that deceleration in cost trend that we've seen the last couple of years really hasn't continued. And I guess the example I would give you is if you look at managed care companies, sort of what people expected them to earn a year ago versus what they actually earned, that number is only up about 5%. If cost trends were really decelerating, or you look at periods of time historically when cost trends are decelerating, managed care companies beat their earnings projections by 10, 20, 30%. It just sort of gives you a perspective for how much or how little cost trends actually have improved.
As I've been listening to this discussion, which has been phenomenal, discussion, one thought that's going through my mind is that the relationship between cyclical and secular factors. You think of the high deductible plans. I mean, clearly the cycle accelerated the movement to high deductible plans. But once you have a situation where a lot of people have high deductible plans, you start thinking the norms in the healthcare system start changing. And that these high deductible plans aren't going to shrink into low deductible plans. If our economy is stronger, probably going to stay that way. And what Sheryl was mentioning about the steering of patients. Again, I think the weak economy, it's provided a good opportunity to do that. But if it works, it's probably, and if it works, it's going to be a matter of, is there a kind of backlash now that there was in the 90s? I don't think there will be. But if it works, in a sense, that again becomes a secular change. And maybe its advance is slowed, but it keeps advancing even if the economy remains stronger. And of course, the Medicare cuts that Bob mentioned, it seems like they're locked in for a long period of time, no matter how the economy does. So one thing, I think we've covered a lot of my questions. Although the one thing I often like to ask and usually don't find much, and maybe I also won't find much, is that because it's so hard to get insights into what is happening with technological change, in a sense. Are there important technologies that are perceived as likely to, expand spending or reduce spending that anyone is aware of?
Well, I can identify one that's in progress, and that is under the high-tech provisions, where the hospitals have to spend a ton of money on implementing an electronic health record, both within their four walls and reaching out to physicians who practice with their facilities. And then there's both a carrot and a stick. If you do it, we'll subsidize. If you don't, we'll penalize. So it's working. So that certainly is, if you can get the data out of that and then analyze that data and then formulate a view of who you're taking care of and how to improve the care you're delivering, it speaks to being able to take risk, because now you know who you're treating and how much it costs to treat them, but it also speaks to being able to change practices, practice patterns, physician practice patterns, quality of care, all the rest of that, as well as your cost structure. And importantly, the workflow through the hospital, which oftentimes is the biggest source of inefficiency and excess costs that I see in the hospitals. So that, I would say, is one element of technology, not a medical technology per se, but it's one way that technology is fundamentally changing the way in which hospitals spend their money today and hopefully act in the future. We're taking a good look at the use of robotics, robotic-assisted surgery, just because it's it's anecdotally, the hospitals will tell you they hate those things because they don't get paid for the cost of those surgeries. There's been, of course, some concern about safety and efficacy of some of the things in the training of the physicians, and we're right back to where we were with the medical device companies in the past, having very, very persuasive marketing, and maybe some physicians are doing the procedures who shouldn't. But those are the kinds of things where technology is sort of a double-edged sword. This is this great, wonderful innovation. It should be brilliant. And in fact, we find out it comes at a significant cost. Other than that, the other place I would say more in your guys' space is to the extent that, technology plays a really blindingly obvious role when it doesn't work, i.e. accessing insurance. But for the most part, it plays a really important role in the normal course of business with the health plans because of the way they interact with the consumer these days.
Yeah, I mean, the only thing I would say, what I hear consistently from companies, not necessarily a new technology per se, but specialty pharma, is really the one sort of constant that you hear about, companies that are worried about what's coming. So it's interesting, Joe Swedish, who is the CEO at WellPoint, was at a panel at the Cleveland Clinic a couple of weeks ago. WellPoint, Blue Cross plan, more exposure to health reform than any of the companies that I cover. And everybody on the panel got that normal question of what keeps you up at night. And his answer was specialty pharma. He's like, I know you guys think I'm going to say health insurance exchanges. It's not. It's specialty pharma. And so you've got the question of sort of how do you manage the cost of that? And then he also brought up an interesting point too, which is that the managed care industry really hasn't come up with a good way to determine who should get these drugs. So right now, most of the decisions around specialty pharma are cost-based. There's very little being done from a value perspective, or he didn't use the word deserve the drug, but basically along those lines. So that would say be the one sort of big cost driver that a lot of companies are thinking about.
Yes, I know when I've looked into this, what I see is that a very high rate of growth, and the base is growing. So it's becoming a more serious issue. I haven't really seen much progress as far as tools that insurers have been able to use to address it.
It's tough because the typical tools that insurance companies use are things like copays, which if you're talking about a specialty drug that costs $100,000 a treatment, like, all right, fine, put a whatever copay you want on it, but after one dose, you've already reached your out-of-pocket max. So those sort of normal things that the plans do don't necessarily apply to the specialty pharma realm.
Yeah, because they've blown past use of incentives, and it really becomes a matter, are we going to allow you to have this or not, which insurers have not had to face for the most part before.
So there might be a desire to sort of, in that area, move to bundled payments and put the provider at risk, and I know there's increasing talk about doing that for cancer treatment, but I have trouble sort of, I hope they can figure out how to do it, but you've now shifted that decision about whether to use the drug to essentially to the physician treating the patient, and I don't know how that works in a bundled payment situation. That's where you actually do.
You want to be careful about what incentives you set. Right now, in many cases, as someone unfortunately said, you're really paying oncology doctors to be drug pushers because they get paid more if they prescribe the higher priced drug, and that's clearly not an optimal model. So what you want to do is pay them for their expertise and reimburse the drug separately, which was a pilot that United instituted. We never actually heard back how successful that was, but I think they did ultimately expand it. But I think that's one thing that we need to do is make sure that the incentives, both for the physician and the plan, are aligned in the best interest of both the payment and the sustainability of the benefit.
Yeah, the concern is paying the doctor not to prescribe the drugs, and that's the concern about moving to a pure bundled payment model.
Well, I was going to say, I think, as you sort of look towards the future, and I do think the future is hospitals and physicians being under the same umbrella, and I think that is an area, like you said, where it takes the incentive for that physician to prescribe the brand name drug, the specialty drug, because they make more, where it'll be, there will be more of an effort to look at the efficacy of the drug and see if there's any alternatives that don't cost as much but provide 95 or 90% of the efficacy of those drugs. And I think as you look at physicians, as they interview new physicians coming out of medical school, I've heard 80, 90% prefer the employed model. And so I think over the longer term, I think when you get the hospitals and physicians aligned there, then their incentives will be aligned.
Good. Got a couple of questions about large employer health benefit strategies. And the first is, to what extent, I've heard anecdotes about large employers taking steps now in anticipation of the Cadillac tax. And was wondering if anyone has any thoughts on that.
This is hard to measure at this point, so it is anecdotal. But large employers are definitely focused on this, and they're not focused on the exchanges to a large degree. Maybe that'll change, and I mean the public insurance exchanges. They're focused on the Cadillac tax. I think it is influencing some decisions. They may not be presented as having been influenced by looking at a bridge that keeps them below the radar or less in the radar of the Cadillac tax. But I think it absolutely is a factor at play out there among large employers from everything that I've gleaned anecdotally.
Yeah, if by taking steps you mean thinking about it and talking about it, then yes. In terms of any real definitive action, I'm not so sure we've gotten there. So yeah, I think everybody agrees that you can't pay the Cadillac tax. Like I may mess these numbers up a little bit, but it's basically like a 40% tax on every dollar over the cost threshold. So it's prohibitive to actually pay the tax. Everybody says, okay, we can't pay the tax. But the employers that are in danger of paying the Cadillac tax are generally city and states, so it's negotiated, union-dominated benefits. So it's not like the employer can just unilaterally say, okay, we're changing the benefit. It's a negotiation process that you've got to go through with your largely union-based employees. And so that's a process. But everybody agrees you've got to do something. Everybody agrees that you need to do it now. You want to make gradual changes over the next couple of years as opposed to just falling off the cliff in 2018 or whenever that tax actually takes effect.
Carl, I just would disagree with you a little bit on that one in that, that I have seen some real anecdotal evidence that private employers not dealing with unionized workforces, that it is actually influencing, not any radical steps, but, on the margin, it's influencing some steps that they've taken with benefit plans. And I think we should watch for more of that going forward.
To that point, I'll offer you both this piece of anecdotal evidence. There's a firm in our business on the West Coast that has about 300 employees. So they have been very generous with their benefits, and in fact, much to their surprise, found out that they are going to be subject to the Cadillac tax. And what they've chosen to do this year for their open enrollment is to maintain that plan for this year, but to offer a high deductible plan as an alternative where they will actually pay part of, as my firm does, pay part of your HSA contribution to fund that deductible as a temporary transitional step. So it is affecting people in our very business because we've been so generous with our benefits to our employees. And I can tell you it's buy side, it's not sell side. They don't treat us that way.
Yeah, one of the ironies with the Cadillac tax is the crazy way it was drafted, and I think the point of it is that this is a tax that insurance companies pay, not a tax that employees will pay. They've actually wound up with something where there is a really hard cap on premiums, as opposed to capping the tax subsidies to employer-based health insurance. And it's probably really difficult for actors to decide whether, would seem to me what an obvious problem, whether that'll be fixed, because it can be fixed without losing revenue, as opposed to, some people when it was passed thought, oh, it'll be repealed, but I don't see that because of the huge revenue hit. But it must add to the uncertainty so much because it is, that can be fixed without a big revenue hit. And to move over to the model that economists have advocated for 40 years. Let's talk about private exchanges. My sense is that most of the private exchanges that large employers have contracted with are actually, putting employees into fully insured products, which cost a lot more than self-insured products. Just want your views about why is this happening, or what is it that is offsetting that higher cost?
I wouldn't necessarily say that it's higher cost in the fully insured products. It doesn't have to be by structure, although it is counterintuitive in that you're directly taking on, for example, the health insurance industry tax that applies on the fully insured side. So now is sort of a funny time to see it happening in that sense. And of course, as you usually do with fully insured, some other state level charges as well. But if you think about the purest model for a private exchange, which may or may not be what emerges from all of this, private exchanges could fizzle. But the purest model would be one where you have many different employers really outsourcing their entire benefits and human resource function to a exchange benefit manager. Aon Hewitt is the most widely cited. And then you have a wide range of carriers ranging from big nationals, multiple site, to ones organized around relatively narrow delivery systems and hybrids in between, offering different levels of coverage to that big pool of employees. And that is a model that isn't incompatible with self-insurance, but it works much better in a fully insured model, particularly when you then think about that as defined contribution to the to all the workers that are and their dependents that are in that pool. Just remember one thing with all of this: the reason there's a structural element to this that private exchange sponsors have to be very careful to maintain, and that is the employer has to still have enough of a connection in there to retain the employer tax subsidy, because that is so often crucial. Of course, we'll see where this goes. If private exchanges work well and public exchanges get the problems resolved, and we may be having a debate a few years from now whether the two should merge and we get rid of those barriers or not.
Yeah, so I'd say private exchanges, I think, are interesting for a certain piece of the employer population. So like most employers that I've talked to have said, if we move to a private exchange, it's going to be anywhere from 5 to 15% more expensive. Industry tax, state mandated benefits, health insurance industry fee, all those things. Now you do have the plans competing against one another on the exchanges, and so that takes the price down a little bit. But Darden, which is a marquee Aon client this year, was very explicit in saying this private exchange through Aon is going to cost us more in 2013 than staying fully insured, or excuse me, staying self-funded would have been. But they don't care. All they care about is that they're setting a fixed amount that they're going to give their employees. I'm making this number up, but we're going to give you $300 a month to go out and buy your health insurance. The key to this whole private exchange is 5 years from now, they're going to give their employees $300 a month to buy their health care coverage. That's all they care about. So the way that I think about who it's attractive to is if you're a employer with a lot of low-wage, high-turnover employees, Darden, Sears, restaurant, retail companies that have largely dominated, at least the Aon exchange, you can be really committed to saying, we're going to keep that fixed contribution. When I talk to Citigroup's benefit manager about private exchanges, what she says is, no way. Why would we pay more over these next couple of years without the visibility of being able to maintain that fixed contribution? If healthcare cost trends rise a lot over the next couple of years, we've got unhappy employees because they're now paying more a lot out of pocket. If the labor market tightens and we start losing employees to Goldman, and our CEO comes to HR and says, we got to do a better job retaining people, well, guess what? That healthcare contribution's going up. So we've just paid more in that contribute. We just don't have that fixed visibility. So I think for that segment of the employer population, private exchanges, probably at least as they're structured right now, not as attractive.
Could I just offer one follow-up to that, which is, I would though point out, the feature that could be a key dynamic in private exchanges is, which can work outside of private exchanges, but if this is the best structure to drive people towards less expensive, tightly integrated provider systems, and to do that as part of channeling payments tied to that population, so that those integrated systems manage the whole medical budget, then it potentially becomes a very powerful cost driver, and some of the issues of worker dissatisfaction can certainly be overcome depending on how the funding is managed over time. So we're just going to have to see how it evolves.
Now, I was going to raise a skeptical question about, couldn't your typical large employer who wanted to put in some defined contribution principles just create a high deductible plan, peg its contribution to the high deductible plan or change it over time, leave the regular plan as an alternative to it if the employees pay more, and avoid the higher cost?
Yeah, it's doable. The only thing the private exchange does is it sort of diverts the blame in a way. So like the employer is doing this to me, they're making me worse off. Whereas in the private exchange, it's not quite as direct. But Yeah, I don't think there's any reason why you couldn't accomplish many of the same things.
Sure.
But again, I would just offer in the private exchange, if you think about the pure version where you've got a large population there, that may be a more efficient mechanism for channeling pieces of the population to different delivery systems because you get a lot more scale involved that way.
Yeah, so then you could offer a plan built around a delivery system that you could never offer as your sole company plan, or even as just one of two company plans. That's a good point. This would be a good time for us to switch to questions from the audience. If you could, those that have questions on cards, if you could be passing them to the aisles. There's someone that wants to right away come up to ask a question.
We'll actually bring the
directly.
microphone to you.
Okay, if you just raise your hand if you'd like to ask a question.
That way you make sure you get it answered.
Yeah, and please, I know who he is, but please introduce yourself before you ask a question.
Hi, my name is Paul Hughes Cromwell from El Parham Institute. The question I have is, if there aren't legislative changes or weakening at the knees, and we're into 14 and the risk pool is bad, don't the insurers still have to respond to the prospective increase in the individual mandate penalty and therefore take into account that the risk pool will by itself start to improve that way and therefore end up with premiums less than would otherwise be the case given that they got this crappy risk pool?
If I just take a quick first answer at that, I think you're right. That's a good point, and it's a factor, but it's probably only a factor in the mix. It's hard to see that step up in the individual mandate, which I think most aren't looking at as hugely effective to begin with, is going to overwhelm is going to be in of itself something that really fixes the risk pool. Particularly if you had a situation where, again, the actuarially normal thing to do would be to put through 30% rate increases because of the pool of people. That's not going to be overwhelmed by the step up in the mandate. It seems unlikely.
Yeah, and I would just add to that so from a pricing perspective, plans historically very much like to take the view of when we actually see it in the numbers, then we'll put it into pricing. We're not going to assume that it's going to happen. The other thing to think about is just the timing of 15 exchange pricing. So you're going to need to submit your rates for 15 exchange pricing in April or May of 14. So from a plan perspective, you're going to have maybe 1 month of real exchange claims experience because of the lag to set your pricing for 2015. So yeah, to Matt's point, like the mandate increase will be a factor, but far bigger, I think, in terms of how they think about the pricing will be the fact they only have 1 month of 14 data, and if things aren't looking great from a risk pool perspective, that'll be dominant.
And that's why I have to say, some of the actions over the last week, while, one might understand the political objectives of kind of eviscerating the risk pool or attempting to do so in order to keep a promise, is really potentially long-term very damaging to the fate of reform. Mm-hmm. Because if these plans have very short window to make a decision about 15, what if they give a party and nobody comes? Okay, now you've got yet another problem, which is not just that you can't get the members on, now you only have a few plans. And in some markets, you don't really have much choice still. So, it's still November 30th. It's still got to work. It's got to work not just for this year, but I think also for 15 and beyond because of what Carl just said.
Yes, my name's James McGee, and I am from the Transit Employees Health and Welfare Plan. So we're a plan sponsor providing benefits to the bus and subway operators for those who took the bus and subway here. We are going to be paying about, on the subject of risk pools, about $1 million in reinsurance fees this year. And as a nonprofit, we have a hard time swallowing that as a subsidy to mostly for-profit insurance companies. So I'm hoping somebody there can explain to me why I'm doing this. And secondly, what should happen if the insurance companies don't need it? Can I get it back?
When was the last time you got something back from an insurance company?
Yeah. Unlikely, I guess, the fair answer on the second part. But really, I wouldn't personally. I don't think it's really a payment to the insurance companies. It's certainly not directly. It's as you know, it's going to fund reinsurance within the individual market, which has actually taken on a great deal more importance now that we're looking at the skewing of the risk pool. And plans are getting more and more worried about, how much money are we going to lose here, and will we have to pull out of this market? Now, it's taking from Peter to pay Paul, or the other way around. Whether that's the right way to do it, I don't know. But the need for that money to offset the risk skew that was already to some degree contemplated going in, and the idea was, okay, let's offer this reinsurance, which kicks in when an individual reaches, I think it's 65,000 as a spending threshold, and goes up to 250,000. That allows the carriers to price the exchange premiums at a lower level than they otherwise would have, and so. That's been key for the price shock, at least being less than it would have been otherwise, and some of the prices looking actually quite reasonable on the exchanges. But of course, it's going to phase down and go away by the end of 2016.
What I would add to that is that the structure of the Affordable Care Act was designed to be self-funded. It wouldn't increase the deficit, and that's how CBO scored it. And I would say that part of it is casting around in lots of different places to find money. And I think probably the thinking behind the reinsurance tax applied broadly is that the people in the individual exchanges are going to be sicker than average, and they're going to cast broadly as opposed to narrowly to look to find the revenue for that. So it's really almost a payment that for something you've always had was perhaps healthier than average enrollees.
Got one over here, and then we'll take the one up front.
I'll stand up. I'm Barbara Tomar from the College of Emergency Physicians, and I had a question about people getting into the exchanges buying some of the lower end plans with tremendously high deductibles. If they are so stuck by the sticker shock of what they owe before their policy kicks in, do you think there'll be a lot more bad debt, both to hospitals and physicians? And then how will that affect physicians' willingness to continue to play on the exchanges?
Right. So, I think the answer is that Wall Street has assumed that all bad debt for hospitals goes away. And that's just simply wrong. Bad debt has nothing to do with treating the uninsured. It's an accounting treatment, okay? So the real question you're asking is, will we still have no pay heads rolling, walking, riding through our doorways? And the answer is yes. Okay, you will. And it is a little bit frightening to see the numbers of the newly insured who use the emergency room, and then look at the high deductible nature of this, and you say, okay, well, how much of that out of pocket is going to be fully subsidized by the subsidy payments, and how much isn't, and how much of it is going to end up in the hospitals? I mean, as I modeled out the revenue and EBITDA impact for the hospitals, I assumed that 5%, basically 5% of these newly generated insured revenues would be balanced after insurance payments are received that's still due and not collectible. But that's just throwing a dart at the board, because we don't have a good feel for what it's going to be. We know it's going to be there. And especially with the higher out-of-pocket nature of it.
And I would say, as I think about sort of things that could potentially be another public relations nightmare, this I think is one of those things that could be that next shoe to drop, as people don't realize if they're buying a bronze plan that they do have to pay $5,000 out of pocket before it contributes a penny, and have 20 or 30% co-insurance. I think from the provider perspective, the question will be, if you had somebody that was uninsured previously that comes in and racks up $100,000, all right, fine, you write off the $5,000, but you're getting paid $95,000, so who cares? Or does health reform result in a lot of people that were previously uninsured that now come in and have $1,000 or $1,500 bills. And so you're just writing those off because they make $15,000 a year. They're not paying a $1,500 bill. If it increases those to a significant degree, then I think it will be more problematic. And one thing I didn't totally appreciate is from the physician perspective. A lot of times physicians don't necessarily understand what networks they're in and what they're getting paid. Like hospitals, you have a contract, and it's not straightforward, but it's easy to understand like where you are and what you're getting paid. A lot of times the contracts physicians sign basically say, anything we offer as the insurance company, you're in unless you opt out. So you may have some situations where physicians find out early part of next year that they were getting paid $100 for a commercial member, and now they're getting paid $60 for an exchange member. So you may see a little bit of disruption, as providers start to figure that out.
One thing I want to mention is that the way the hospitals, Carl's absolutely right, that there is going to be the sticker shock and there are going to be these issues, and hospitals should be grateful for that $100,000 patient because that patient was going to show up at their door anyway and they were going to have to pay for them anyway. So the notion that all things from reform are just degrees of good for the hospital got its root in that. That's not true, but it got its root there. One of the things hospitals can do to mitigate the impact of getting low spending uninsured with high deductible, so low spending from the hospital's perspective, like $5,000 spend for a $5,000 deductible, and then someone else gets the benefit of the insurance. One of the things they're doing is really targeting the frequent flyer. They know who the uninsured are. They're probably the one entity in the entire system who sees the uninsured on a regular basis and knows exactly who they are, where they live, and what's wrong with them. And they're using that information in a HIPAA-compliant and legal way to say, you are exactly the folks that the ACA was designed to help, and you can now enroll. Now, they're not sending out the 35,000 flyers at LifePoint or the many multiples of that at HCA because the exchange isn't working. But as soon as it does, they're hitting the mail. So, don't expect mail to go quickly in Tennessee after November 30th. But that's what's going to happen. And they're really going to try to manipulate their own risk pool, as it were, to optimize their ability to get paid for the services.
Good. Jim,
No.
do you have any?
No.
Okay, so the final question.
Alexa Page, West Health Institute and the American Academy of Orthopedic Surgeons. I wonder if you could help me with what I see as a conundrum between the narrow networks that are being issued on the exchanges. And to speak to Mr. McDonald's point, many of my surgeon colleagues are very surprised and very worried about finding out that they're in these networks. But what is also happening is the consolidation of hospitals in markets so that suddenly you no longer have that. So a shift between the hospitals and how that fits with the payer network, the narrow networks.
Yeah, I think we're obviously in the not-for-profit space. We're seeing a lot of consolidation. I think I would expect that to accelerate or at least continue abreast. I mean, in the not-for-profit space, it's been very fragmented. You haven't seen consolidation because generally it's been financially driven. I think now you're seeing it strategically driven. There's still a lot of consolidation to take place, and I think in terms of the narrow networks, it really depends on each market that you're talking about. At this point, I don't know, Sheryl, what you're seeing, but the narrow networks, we've seen a lot of interest in that, a lot of discussion about that, but in terms of where they're getting set up, I think it's still, sort of in its infancy stage right now in regards to what organizations are setting those up and what they can negotiate with the payers at this point. But I think it's going to be coming, and it'll probably accelerate as you see more consolidation, particularly in the not-for-profit space, where you can get good coverage. I'm from Chicago, and so if I look at Advocate, for example, Chicago is a very fragmented market. Advocate, they're the biggest provider, but they still only have a market share of maybe 18% in that marketplace. But if you look at where they're located in the suburban areas, they've got a good opportunity to really drive change there and consolidate that market because they're the clear leader in very good marketplaces.
So, we're seeing all different kinds of consolidation, and I would argue, all of this is driving hospitals towards, capacity is going to leave in some markets and be built in others because we're not aligned with population, and that's part of it too, is when you, especially in the markets where there's excess capacity, especially of inpatient beds, okay, and not enough capacity of other outpatient and other. But what I think we're still seeing is, while consolidation is certainly playing a role, the hospitals have been very reluctant on exchange-based contracts, the for-profit hospitals. They have them. I mean, on every conference call they get up, because we need it, we want to know it, they get up there and tell us how many contracts per hospital they have with the second lowest price silver or the bronze and how much narrowed the network is. And so they are all engaged in more or less one contract of a narrowed network type per hospital is what they've told us, at maybe 2 at most, but not many more than that, which I guess makes sense. That you wouldn't, if you have that many narrowed networks, how narrow is the network really, okay? But the hospitals have been very reluctant on the exchange contracting side to give anything up because no plan can guarantee them volume. So why would you agree to give pricing up if they can't give you the volume? So the reason that they're even thinking about these narrowed networks and why these contracts got signed is because they understand that this is the first step on a path toward being able to get assured volume, and they're not going to give up much in terms of price or terms of the contract to get volume that doesn't yet exist. That could change over time, and those networks could get much narrower to the point where, you know, it becomes almost vertical.
Good.
But not yet.
I think it's time for us to take a break. And it is 10:37 now. Let's be back by 10:52. Nothing like digital watch. So we'll start that.